Hello, everyone. Welcome to Brainmap. This seminar series is co-sponsored by PIPOD-funded Center for Mesoscale Mapping, housed in Martinos Center. It's my great pleasure today to introduce Dr. Onur Afacan. Dr. Afacan is an assistant professor of radiology at Harvard Medical School, co-director of the Queen Research Group, and scientific director of the Research Imaging Core at Boston Children's Hospital. He received his BS degree in Middle East Technical University, MSc degree at Bilkent University, and a PhD degree from Northeastern University. All in technical, electrical, and computer engineering. He joined Boston Children's Hospital in 2012, where he conducted postdoctoral research at the Computational Radiology Laboratory, where he was trained as an MRI physicist. He is currently a principal investigator in multiple NIH fund and foundation grants. Also, he is a fellow Turkish, and I just want to use this opportunity to just send my thoughts to my country, who actually had a quite big devastation last week. Thank you very much, and the stage is yours.
Thank you very much for the introduction, and thanks for reminding about the unfortunate, horrible event that happened last week in Turkey. We were all devastated, but hopefully everything will become better with the help from friends and family. Okay, for today, I will talk about some of the stuff that we have done recently. I actually just received, like last year, my 10-year gift from Boston Children's Hospital, which it was like a espresso machine, so which means I've been there for 10 years. So this will be like what we have challenges that we encountered in the last 10 years and what we have tried to achieve. Okay, so the biggest one is the patient motion. So I will talk about probably half of the talk on this because we are imaging children. They're uncomparative. They cannot follow instructions, especially the younger ones. So we need motion robust imaging solutions to improve image quality. The size of the brain structures is smaller. We do lots of fetal work and newborn work. So because the size is smaller, you want to go even higher resolution. I mean, obviously high resolution is wanted anywhere, but it's even a more crucial task for newborns. And finally, different than imaging adults, the brain is consistently changing, and myelination is a big one. So we try to develop methods that characterize myelination, and we worked on improved quantitative imaging techniques. So basically, this will be a three-part talk. The part one will be about motion and distortion correction. The part two will be implementing high-resolution imaging methodologies. And the final part will be implementing quantitative methods to measure myelination. Okay, so if you're familiar with MRI, you must be familiar that motion has a huge effect. And this is an image of a newborn that was acquired. So as you can see, nothing is visible. It's completely non-diagnostic. So what happens is, because in MRI, we get information in the frequency space, when the patient is moving, the K-space encoding is incorrect. So this results in imaging artifacts like this. And this creates a huge burden in clinical practice because you have to repeat the scan because radiologists cannot read this image. It's an added time and cost. And what we currently do at BCH for imaging younger children is sedation. If you look at this graph, if you're around like age of 1 and 3, you're almost certainly going to be sedated. It's almost like 60% 4 to 6 years old. For newborns, we actually have a method called feed and wrap, where the mother feeds the baby. We wait for the baby to go to sleep. We wrap them, and then we try to image them. That actually has a quite high success rate, so that's why the sedation rates are low. And the sedation has a high cost. There's a risk of damaging the brain, so we would like to avoid that. So first, what we did is we tried to estimate how do children move. So we worked with a company to develop a motion tracker, and we attached the motion tracker into 82 pediatric subjects. And our results show that, so then we took these images and then showed them to a radiologist, and they graded them into like a 4 scale, where whether the images are diagnostic and whether they see motion artifacts. And our result is 15% of them are completely non-diagnostic, and 35% of the images had motion artifacts that might affect the diagnosis. And one thing I would like to highlight is this is actually a subset group, because these are the children who were not sedated. So someone already made a decision that these kids can actually have a non-sedated scan. But even in this like picked group, right, we had these numbers that would affect the clinical workflow. And since we have a tracker, we actually looked at how the children move. And the two actually the motion metrics that we found the most correlated to imaging quality was motion free time, which means how much of the scan the kid wasn't moving, and the average displacement, which I think will be an obvious choice. So, as I said, we actually tried lots of things, and that's actually one of the, not to spoil, but one of the conclusions is you need lots of strategies. We first work on trackers, and we use like an electromagnetic tracker and optical tracker. Then we worked on navigators, and finally we start working on self-navigated sequences. The first project we did was with a company called Biomedical, and actually I see some faces here also. We were in the same project here at MGH, mostly with Andre van der Kove. And the idea is that this is like a pickup coil with this is like a tube with 6 pickup coils in each side, and we apply like gradients, as I'm not sure you can see here. We apply like activation gradients here, and then we measure the signal induced on these coils, and that combined with some kind of a gradient mapping process can tell us how much motion there is. So we actually started with one sensor, and then at the end we developed something like a headband with multiple sensors to reduce errors. So basically we have position and orientation vector from each sensor, and we did lots of tests, and our results that we published show that the position location accuracy is around 0.2 millimeters. And after that, we tested this in clinical MRI scans. We recruited, I think, like 25 subjects with this. And here's an example on a real subject where we apply the motion correction methods. And you can see that in the zoomed one, the imaging artifacts are much reduced when we use like a external tracker. So the next tracker we used is an optical camera. And I think there are lots of work here as well with optical camera systems as well. The camera we used was a product of Siemens Medical Solutions, and this is called the Kineticor. And this was developed by Maxim Zaytsev like 15 years ago. So the idea is you watch with a camera where you follow a moire pattern on a subject's nose. There are like 2 markers here. And from these, assuming that the motion is rigid, you can actually estimate how the patient's head is moving. So for this, we actually use like a prospective motion correction where the object pose info is sent back to the scanner, and then RF gradient and updates did happen, and then the images are reconstructed. For this, we work with Siemens and especially Tobias Kober, who developed a motion correction framework who in real time, without changing anything in the sequence, can update the RF and gradients. So here are some results, and you can see some results from a 12-week infant. And as you can see, when the prospective motion correction is off, results are quite bad. And when we turn on the prospective motion correction, the results are pretty good. So this looks great. So then why didn't we stop doing research, right? So we have some trackers, cameras, and the big problem we had was clinical translation. Because, for example, this system looks great, but most of our kids already have an injury. They have lots of stuff in their faces. So, and then you need like a line of sight for the optical cameras to work. Same with electromagnetic tracker. The technologists and the nurses hate us putting something on because there's already like these people are coming from a surgery. They have lots of surgical stuff. So none of these methods really we could adapt to the clinical practice. So then we started working on navigators. And I know there are like lots of navigators in the world, but We found the one we actually really liked, and we worked on this for the last, I think, 5-6 years. And it's called an FID Navigator. And if you're wondering what's an FID Navigator, it's literally reading the data while there's nothing happening in the sequence. So if you have any empty space, like 5 microseconds, 10 microseconds, you can actually put an ADC block and read data. And what we are actually leveraging here is, if you look at the image on the right, each coil is sensitive to a different area in the brain. So when the subject is moving, the FID signal from each coil will have an increased signal. And that will let us which way the subject is moving, because the FID is basically since there is nothing happening, there's no encoding, it's the integral of the signal multiplied by that coil sensitivity. So this is great. And our aim is to see if we can develop real-time motion measurements using these rapid FID navigators. First, I will show results from motion detection, though, because that's very easy to do. So you basically put this ADC block in your sequence, and you can see here difference. Again, this is like a real patient data. You can see how the FID navigator is changing in different grade of images. And you can see that when the grade is low, which means the image is non-diagnostic, the FID has like much bigger changes. And we show that you can actually generate some metrics based on correlation. And you can generate like an image metric. And we show that the diagnostic grade is quite related to this FID-Nav parameter. So in real time, if you put this FID navigator in your sequence, you can follow how it's changing. And in real time, you can have some kind of a diagnostic information, even in the middle of the study. But our goal was not to just detect motion, it was to measure motion. The problem is FID, as I said, is just the integral of an image, right? So how are we going to get a motion measurement information? So then our idea started with getting a reference scan that matches the exact contrast of the FID. So basically, the sequence on the left is how a standard sequence works. And this is the FID navigator that we add just before the readout, right? So what we do is we do like around like 8-10 second scan before the real study, where the imaging gradients, the imaging readout actually matches the FID nav's echo time and TR and everything. So we use this to generate like a model of how the signal should change. And what we do next is we basically generate a forward model where we have an image from this very low resolution image. We have coil sensitivities. And then what we do is we simulate relative motion between the coil and object in the 6 degree of rigid motion parameters. And from these, we can actually generate a calibration model with a matrix A. And from this, we solve an inverse problem that matches these now calibrated parameters, so basically the FID parameters, into the 6th degree of motion. So basically, we apply this in volunteer experiments first, where you measure the FID navs, right, in real time. You put them into the calibration matrix that we generated. And here we told the subjects to nod their head, and here's we told the subjects to shake their head, and the motion is around like 10 degrees. And you can see that the FID motion measurements quite follow the patterns, in both motions. And we use these motion measurements again to retrospectively correct the motion. And you can see here again, as volunteer is told to not move on the left, then move, either shake or I think in this case, it's to shake their head in the middle of the scan a couple of times. And as you can see, we can get lots of correction and the images are almost as good as the no motion one. Sure.
What kind of
so we actually, this obviously starting off this project, this was very random. Now we have like some kind of a system where we show like a dot and then you follow the dot with your head. So there's an LCD screen and then we tell you to, there's a dot in the middle of the screen, and the dot moves left and right, and then you follow the dots with your head. And then depending on that, so it's like a more controlled experiment. But yeah, go for it.
No, maybe you're getting it. I wanted to know the type of motion or when it's happening, something like that to affect you.
Yes, actually, okay, so that's something I didn't put here, but when we started this project, that was one of our thoughts, right? So for example, one obvious decision was, so if you're familiar with how the MRI is acquired, right? You acquire different frequency lines. And our initial thought was, if you are moving in the middle of the case space, right, the images should be much worse. And actually, we have results showing that the effect is less than that. So, and yeah, so different kinds of motion create different artifacts as well. So that's also, especially there's a big difference between translations and rotations. Rotations are much worse than translations because translations just create like phase artifacts, whereas rotations are almost evil. That's my like 1 minute. I hope, was it? Okay, thank you for the question. And I actually forgot, please feel free to interrupt anytime. Actually, that was on my mind, but okay.
Before we start, they are asking someone up from here. Could you repeat that?
Oh.
No problem for now.
Okay.
Just write it down.
Okay.
But just for the
For the next time I will do it. Okay, so then we basically replaced our optical tracker pipeline with real-time measurements from the FIDs. And you can actually see what happens when there is the motion correction is off and there's no motion on the top left, and when the PMC is on. And here we are showing that we don't affect the image quality when there's no motion. And here on the bottom, you can see that what happens when the volunteer is moving, and we actually apply prospective corrections just from FIDs. And this is like one more result highlighting the same thing, I guess. These are two different subjects, and again, when there is no motion and when there's motion, the same result. We don't affect the image quality when there's no motion, and we definitely improve the image quality when the PMC correction is applied. So this is great, but if you actually are careful, and if you're a radiologist, when you look at the images, you can actually still see lots of remaining artifacts in the images. And we actually spend lots of time, why is that? And one of the things that we worked on to fix that is Cartesian versus radial acquisitions. And the problem, I think there's a problem with Cartesian imaging where they're more sensitive to motion. And the reason is, okay, this is what people mean by Cartesian imaging. And this is, I think, if you get a scan if you are scanned for a clinical purpose at an MRI, there's a 99% chance that you'll be scanned with a Cartesian acquisition. So this is your brain, and then we get samples from your brain, and then motion happens, right? And then we correct for the motion. And what happens here is, as you can see, there is like a giant gap here, and that results in unrecoverable motion artifacts because there's no frequency information. And even if you correct for prospectively, you'll have some errors in your prospective measurements. And so you still have an effect like this. So you'll still have some remaining artifacts unless you reacquire the data. So what we found is if you do like a radial imaging, the artifacts are much more recoverable. And the reason for that is the frequency information is more dispersed. So when you correct for motion, it's more around all the image, and then it's very hard to see visually. So we started working on radials, and one nice thing about radials is they actually all pass through the center of the case space. And here I'm going to show results from a 3D radial, but some of the stuff we also applied to like a stack of stars as well. The nice thing about the 3D radial is every point passes the center of the case space. And if you remember what I talked about FID-Nav, it's literally when there's nothing happening in the sequence, right? When there's no encoding. So every radial line actually has an FID-Nav encoded inside. So we try to leverage that. And the previous work is with radials, usually self-navigation. So basically, let's say the subject has like 3 distinct positions. So you reconstruct images on these 3 positions denoted by blue, green, and red spokes, right? And you build each spoke into different motion states. and then you co-register the navigator images, and you assume that there's nothing happening other than these motions, right? But we actually have motion information at each line, because each line passes through the center of K-space. So we basically extended our FID-Nav motion measurement system to the center of K-space. But we obviously have a big problem because this is what happens in practice, and they actually do not cross the center points. So this started thinking us how we can measure these things, right? And these are basically eddy currents and field inhomogeneities. So we decided to extend our work for motion measurements from FIDs to motion plus field measurements. So basically the idea is now if you remember our previous model, we did have an FID navigator, right? And it consists of the image multiplied by the co-sensitivities, and that was enough for the motion measurements. Then we added a third term, which is basically the changes in the field or the inhomogeneities, right? And then we now solve for not one thing, but two things. We solve for the motion parameters that I described in the, like the 6 rigid body motion parameters, X, Y, Z translation, and then the 3 rotations around 3 axes. And then we also now solve for B0 field inhomogeneities. And we did some experiments where the volunteer moved their head up and down, and that's intentional because that's the one that creates like the biggest field changes. And what we show here is we can actually measure the field changes successfully with FID navs while also measuring the motion parameters. And this actually has had multiple uses. The first one is this actually improved our motion estimation. We can now correct measure and correct for field changes. And in the next slide, I will show we use this to improve 3D radial MRI reconstruction. So here's the result, just to show you how this works. So the red line is basically a navigator that we had. External tracker. It's the EM tracker that I mentioned, right? And the blue curve is what happens if we use just FID, we use FID navs just for motion measurements. And as you can see, the signal is quite noisy because each line isn't passing through the K-space center. So basically what we are measuring is some kind of a noise or some kind of a pattern that depends on the angle of the radial lines. But when we fit motion and field to the same data, we actually got, especially this is, I guess, a good example. We got motion measurement parameters almost matching the external tracker. And here are some results. And again, this is the standard experiment. There's no motion reference scans on the left. When there's no MOCO applied, when the subject is doing some kind of a shaking motion, which means left-right, like shaking like this. And there's an external motion correction, which is the electromagnetic tracker in this case. And the image on the right is using measurements from the center of K-space that are corrected for field inhomogeneities. So is there a problem with FID navigators? And there is, which is, if you remember what I described, you need to match the contrast of the reference scan to the FID navigator, right? So CMAS actually has a very interesting product we actually just started playing with. This is called a beat sensor. This is like a beat sensor developed by some other group. So this is basically an RF transmitter that's separate from the MRI signal, MRI system. And what it does is it transmits a frequency that's just a little bit off the center of the frequency that we measure. And you can actually, we actually showed, the nice thing about this is because it's not related to the imaging gradients or the imaging RF, it actually gives independent motion measurements. And in a sense, it's almost identical to a FID navigator. It has the almost same equations. It's a little bit different in terms of how the diffraction works. But what we showed is we can actually use the signal from what we call a pilot tone to improve image quality as well. And we will actually present these at this year's ISMRM. Okay, this project gave us like the project about correcting for radials gave us the impression that correcting for motion by itself is not enough. So you have to compensate for secondary effects, what I call the secondary effects of motion. And I will give two examples from that. And the first one is motion-induced changes in the B0 field. As I said, you're in the scanner, you move your head, let's say, up and down. You have some air in your sinuses, right? And that's now in a different orientation with the MRI scanner. And so that creates like a field change. And you can actually measure this using a field map. So we asked the volunteer to start scanning position 1 and scanning position 2. And we basically look at the difference and fit a model, and we calculated the field map difference. And if you use like a static field map, which means you have the perfect motion measurements, but you use the field information from position 1, you get the image on the left. And this is for an EPI scan with around 10 degree of rotation with prospective motion correction applied. And as you can see, there's like quite a bit discrepancy, especially in the frontal cortex, where the sinuses and there's like an airborne tissue interference. And what happens if you use a dynamic field map? Basically, you get like an almost exact match. And the second thing is actually the B1 field changes. And when I say B1, it's the receive field. So, and the problem here is, let's say the subject is moving, right? So you can make all your rigid body motion assumptions, but unfortunately, the coils are not moving. So the head is moving with respect to the coils. And now the signal each coil measures is quite different. And we are highlighting that here. This is the original position. And you can see that this coil is measuring lots of signal in this area. And then there is motion, right? And you correct for it prospectively. But now that coil is measuring signal from a different area of the brain. And if you don't correct for it, here's an example where there's no motion on the left reference image. There's motion plus prospective motion correction, and you can see artifacts remaining. And there's actually some nice work from Stanford, from Dr. Bammer, and then there's like it's called an augmented recon, where you can actually put the B1 field information into your image reconstruction code. And this actually worked pretty nicely, and we removed most of the artifacts. Okay, so then I hope I convinced you that steering is not enough. If you're convinced, this is another example with an EPI. I'm showing a difference image between position 1 and position 2, again, prospectively corrected. And you can see that there's lots of differences in the frontal cortex. But the correction example I showed was an easy one, right? The subject was in position 1, and then they moved to position 2, and we got field mapped in these 2 positions. So, but ideally, what you want is a field map at every time point that we're acquiring, right? So the easiest way to do in EPI is you can get like a second echo. And this has applications in fMRI and diffusion. In fMRI, you can use these 2 echoes to calculate like a field map because they're with different echo times. In diffusion, it doesn't work like that because you're getting spin echoes. So the thing that the whole literature does is acquiring like one AP, like one scan that's anterior posterior in phase encoding, and the other scan in posterior anterior in the phase encoding. The problem is if the person is moving, these things don't match. So our solution was to do like a multi-echo diffusion weighted scan. So, and this was literally adding like another echo to the spin echo sequence. So this is a 90-degree pulse and a 180-degree pulse. These are diffusion gradients. And this will be like a EPI readout. And normally this is like the standard diffusion product sequence. And what we did is we did 1 more 180, and we actually rotated the way we read the K-space readout. So we rotate the frequency and the phase encoding directions. So this does is we can actually estimate from these images, like these images, you can calculate a field map, and then you can use this field map to correct your prospective or retrospectively corrected images. And again, you can see we have like a much better alignment. I think I forgot to mention the red ones are the EPIs highlighted on like a T2 weighted image. So ideally, we want them to match. And here's an FA map. As you can see, we have lots of unwanted, I will say, signal increase in the frontal cortex because of this effect, because some of the diffusion directions are like this and some of them are like this. And when we do like multi-echo corrections, we improve these results. And we apply this with, again, thanks to our collaborator, Tobias Kober, and his MOCO framework. We actually first started applying using the optical camera. So basically we feed the motion information into the MOCO framework from the camera, and we acquire one image AP, one image PA, as we can see here. And we use an algorithm called top-up to correct the images. And here's the important result. So when there is, okay, so this is the same image, same subject, same images. When there is no MOCO applied versus MOCO applied, and this is with no distortion correction applied and with this distortion correction applied. As you can see, even when there's motion correction applied, there's still a difference between the structural image and the diffusion weighted image. And when we use our methods, there's like a much better match between the structural image and the diffusion weighted image. And we actually started doing this in clinic as well. And the nice thing about this is it's actually quite robust to motion, this algorithm. And here's a subject that moves almost all the time in the scan. And these are not small motions. These are like 6 millimeters and I think 7 degrees of rotation. And this is the end result. This is like a corrected FA map and a color FA map, and you can almost not see any artifacts in the images. So we use optical tracking for most of the work, but in the next part of the talk, I will talk about some slice volume registration methods that we use to create high resolution images. But we basically, the idea is in diffusion MRI, each slice is acquired individually. So you can, if you look at the images, when there's motion, the images look like this. So you can get each slice and register to a volume so that you can have motion measurements at each time point. So this will be like a self-navigation. And so there are currently methods. I think there's even a software called Firm that looks at volume-to-volume registration. We actually did develop a software that does real-time slice volume registration results. And you can see that I think the thing to highlight is it actually catches the real curve much better than the volume measurements, because when you are registering a volume, you are coming like a TR back, right? So if your TR is like 10 seconds, you are 10 seconds behind. And we show that using our methods, you can do improved temporal SNR when we are correcting for motion compared to volume-to-volume registration. And we currently have a software available that you can download, that you can install on your scanner, and it will tell you when your subject is moving during an fMRI, and it will tell you on a slice level. Okay, so going back to the dynamic field changes, this is actually a big problem, I think bigger problem in 70, and we started actually collaborating with some great people from here. I see Jason Stuckman here and John Polomany. And we started to think about how we can adapt the FID Navigator-based field measurements, not motion measurements, to correct for respiration and subject motion-related field changes artifacts. So here's basically the idea is we show that FID-Nats can, which I will describe in the next slide, FID-Nats can measure and retrospectively correct for spatial temporal field changes. And you can actually see these are the motion measurements from Shimming coefficient measurements from an FID navigator. And here you can see that when we use Shimming corrections, we get much better looking images. But retrospective correction is slow, so we decided to do everything prospectively. So our aim here was implement real-time Shimming with FID-Nav field measurements. So the idea goes like this. It's very similar to the FID-Nav motion measurement idea. So we have like a 15-second calibration scan, and we calculate a phase offset. And instead of motion measurements, we simulate effects of different V0. So we change the F, like the frequency of the measurement. We change the X and let's say Y field changes. And now from this, we measure we found a calibration matrix. And we put an FID navigator in our sequence, obviously. We measure the FID nav. From this FID nav, we solve an inverse equation that tells us how the field parameters are changing. And we actually feed it back to the MRI system, again, using the motion correction framework. And in real time, change the field. And here are some examples where the subject was asked to deep breathe during a scan. And I'm not sure if you can see the changes, but these are the shim off and prospective shim off and on. And the images on the left show the before correction field changes versus after correction field changes. As you can see, we have much reduced field changes, and then the image, especially in the frontal cortex, is much improved. And these are some scans that we acquired actually here at Martinos Center at your 70. And again, the subject is asked to deep breathe and touch their nose in the middle of the scan so that the field is different. And this is, you can see the images changing between shim off and on. So is there a clinical application? And we found one clinical application, which is the 3D EPI. So we started our institute using 3D EPIs for SWIs because it's faster. So you want to image faster in children. And there's actually a real clinical application in multiple sclerosis where the 3D EPI can be used to find central vein sign. However, the 3D EPI, because it's an EPI-based algorithm, is even more susceptible to motion and physiological motion. So we did implement a sequence where FID navigators are used to estimate motion and field in real time and correct for these fields. And we first tested on phantoms and on volunteers. And you can actually see that this is actually just showing the effect, sorry. So you can see that when the volunteer is deep breathing, the SWI maps generated from the 3D EPI is quite distorted and lots of artifacts. And when we use FID navigator-based field corrections, you can actually see that the images are looking almost as identical to the reference images. And we are going to present this at this year's ISMN as well. Okay, so this concludes the first part of the talk, which was the biggest part. So motion is still a challenge. As you can see, I presented almost 10 different methods, I think, and almost none of them are clinically adapted. And I think there's 0 clinically adapted motion correction strategies. I might be over-exaggerating, but I feel that way. So we kind of gave up on the external trackers because we had lots of problems in adaptation to clinical practice. We are very high on radial MRI at the moment. If you ask me how we should correct for motion in moving children, I will say I think you should do radial MRI because it's very forgiving to artifacts and errors in your motion measurements. Prospecting, I hope I convinced you that even if you prospectively steer, it's very promising, but you still need to correct for secondary effects of B0 and B1. And we have lots of work in other body organs that I really restrained myself to not put. They're even more challenging because the rigid compensation is not enough in these, but that's a different talk. Okay, so this brings us to our second part of the talk, which is, I think everyone would like high spatial resolution, but it's also a really critical problem in newborns and fetuses because they have smaller brain structures. And currently what we concentrate on is T2 imaging. And the reason is that the current clinical protocols for newborns and fetuses rely on high in-plane resolution T2 imaging with thicker slices. So we started working on how to improve this. And I think the story started with fetal MRI. And I know that Dr. Golipur gave a talk, I think 2 months ago or 1 month ago. So I will try to skip this quite fast, but it actually gives a nice story. So this is how fetal MRI is performed. You get multiple images in different orientations. And if you look at the images, they actually look good in plane. But if you look at out of plane, they don't follow a structure. So what we developed in our lab is we developed a technology that corrects for inter-slice motion through robust slice volume registration. And then we put these motion corrected slices into a scattered 3D space. And then we use something called the super resolution volume reconstruction to estimate the isotropic image. And this actually worked great. And it's almost clinically adapted at our institute now. So, and here's the initial estimate of a volumetric image, and here's a corrected image, day versus night, I guess. This is like, this has been working great for us. And we try to adapt this into diffusion weighted images. And here's a example. Okay. So the good thing about diffusion imaging is it has higher sampling rates. So we even have better characterization of motion. But the problem is the contrast is varying and the resolution is lower. And so here's an example of a color FA of a brain fetus of the scanner. As you can see, it's complete garbage. So we worked on some motion robust diffusion techniques, and the pipeline is almost the same. We have a stack of diffusion scans. We detect and remove motion and estimate slice level temporal head motion. The one difference here is we actually did apply a Kalman filter to improve stuff. And there is also a diffusion tensor matrix estimation. And here are some results. So the one on the left is the original image, and we have some volume to volume registration, and our results are the one on the third column. And here's the ground truth from no motion scans. Okay, so this work led to, I talked about super resolution, and we worked on that a lot. So basically the theory goes like this. So you're acquiring like different orthogonal images that are high in plane, that have high in plane resolution, but they are thick slicing. So the problem here is when you combine these images, and if you're like an MRI physicist like me, so you'll notice that this will come down to something like this in the frequency domain. So there's some high frequencies that are missing in the data. So what we implemented with one of the fellows we have, Yao Sui, who left to become a faculty member in Beijing University now, is some kind of edge preserving regularization to preserve the edges. And for this, we use like a gradient operator to find the gradient guidance in multiple scales. So the basic algorithm goes like this. This is our forward model where you have a desired high resolution image. You have motion, different size profile, different sampling, and you have Gaussian noise. And then this is what we want to solve. So basically, we want to go from this side to this side, right? So here we have low resolution images. We can generate like a mean image. But what we do is we apply like our gradient guidance to improve the edges of the image that we have. So this led to multiple publications. And here's an example that was applied on, I think, a newborn, I think a newborn data set. I'm actually wrong. And the one image on the left is the standard generation of super resolution. The one on the right here is using the gradients prior. And as you can see, this is here are like some highlighted images, like zoomed. And you can see here in the hippocampus, you can see much better structures. And here's actually the neonatal exam, and then you can see much better structures in the here as well. Okay, so if you were worried until this point that there's no deep learning in this talk, you can rejoice. So here's the deep learning slides. Actually, I have a couple of more as well. So basically, we got really good results with the gradient field. So if you have a correct gradient field, we can get really good reconstructions. So Yao worked on generating like a CNN network that estimates the gradient fields from like a low resolution set. And the nice thing about this is, since we have like high resolution data in plane, we actually have ground truth for some of the data. So what we do is we take batches and slices, and we generate like a high resolution image from these, apply a gradient operator, and use that for like for CNN to learn. And we feed like a low resolution images, and the CNN learns the high resolution gradient field. And we actually started doing this on a subject-specific way. So for this, we use a method similar to the deep image prior. So you start with the initial guess, like this. That doesn't look like a brain. So you have a generator network that generates brain-looking images, and then you put these images into a degradation networks, and then you have the low-resolution images that you acquire, and then you look at the signal loss between these, and then you back propagate for your generator network. And here are like some 4 iterations, and you can see that starting from this image, we go more and more into like a image that looks good. Sorry. Okay, and then we apply this to a neonatal data set as well. And I think it's best to look at the zoomed images, and then you can see that the initial images are quite blurry, and our methods generates high images with high quality edge information. Okay, is there a clinical application for this? Yes, so this is a project I've been working heavily in the last 10 years, and it's basically lesion identification using MRI in epilepsy surgery planning. So the motivation here is that if you can identify a lesion using MRI, it improves your surgical outcome by almost threefold. So, and we know this because they do histopathology on these patients, and then they show unidentified lesions that are not found by MRI. So we basically applied all these methods that I talk about: motion robust, super resolution, and we also combined it with a phase-sensitive immersion recovery. And the image on the left are like a standard MPH, 1 by 1 by 1. Then the image on the right is our contrast optimized super resolved image, 0.5, I think 0.4 millimeter isotopic resolution. And you can see actually there's like a, if you're a radiologist, there's like a huge focal cortical display here. It's almost non-visible in the MP and MP range image. So in summary, it's possible to generate high resolution images from multiple low resolution images. This has applications in lots of T2 images, mostly fast clinical and haste. We worked on slice volume registration for this project and also for the motion project. We have like a tool for that. You can download the tool to monitor, stop, or reacquire your fMRI or diffusion data. And this brings us to our final part of the talk, which is myelination, measuring myelination. So for the pediatric populations, myelination is an important marker because it's an important marker for the developing brain. Also, it's an important marker for the demyelinating diseases, and the one I'm interested in is multiple sclerosis. So current myeloimaging techniques are not clinically adapted, and the reasons are, I think, the long scan times, low test reliability, and loss of artifacts. So what's myelin? Myelin is a layer of dielectric material derived mainly from lipids, and it's used to optimize overall brain function. And it also improves the communication because the communication is faster if the tissue, the axons are myelinated. And it's a huge problem in multiple sclerosis because the lesions basically are demyelinated axons. So how can we measure myelin? So there are lots of methods. Again, none of them are clinically adapted. Magnetization transfer, myelin water fraction, and the T1-T2 ratio. And the one that we were most interested in is the myelin water fraction. So the idea goes like this. So you do like a spin echo experiment, but you acquire multiple echoes of a curve. So you acquire echoes at, let's say, every 10 milliseconds. And you look at this, you can call this a T2 relaxometry. And if you look at this data in the T2 domain, each peak here corresponds to a different part of the brain. And the part we're interested in is the blue part, which is the myelinated regions. And this happens because myelin is a lipid and it's a large protein, large molecule, and the magnetization is lost. So the T2 decay curve is much faster. So if we can find this, the difference between this blue curve and the red curve, we can have like a myelin marker. So, however, as I said, the acquisition time is quite long, and conventional myelin water fraction estimates are noisy due to post-inverse problem. We are basically trying to solve like a multiple parameter fits into like a multiple data points. And again, going back to deep learning, there have been some methods that have been proposed that show you can get much better quantitative parameters using deep learning that you can use it to improve parameters, I think. However, training is limited. So who has data that has T2 relaxometry on like 1,000 patients? And I think the answer is no one, because it's not a clinically adapted technology. So our aim was to develop a generative model for synthesis of 3D data sets that are realistic that we can use for myelin mapping. So we actually start with a data set of brain tissue segmentations. And actually use something that was developed here at Martinos and MIT, which is called Intrinsic. And so basically from a data set of brain segmentations, you can generate some spatial transformations on different segmentations of the brain. And now we have a model, the model that I showed here, that there's a T2 decay curve with this equation and different parameters for different tissues. And we simulate these each region with different parameters. And we also apply a spatial Gaussian mixture model so that they look more like a brain, like a realistic brain. And we actually can estimate multi-component T2 distribution that we have a ground truth for. We also do like some MR physics where we apply like a B1 inhomogeneity prior and also some stimulated echoes. We use this with Hennick's echo pathways algorithm. And in the end, we have images that look like this, that look like realistic brain images, and where we have the ground truth myelin information. So we first tested this on like synthetic data. And so here's a generated myelin water fraction, and here's a sample signal from one of the middle echoes. And these are previous methods, and this is our method. And as you can see, the nice thing about this is, as you reduce the SNR, which means you are imaging faster and faster, our method is much more reliable, and then the test we test between the SNR 80 and SNR 20 is much higher. And we tested on some volunteer data as well. So here's a T1 and T2. These are real data. And again, these are the common methods. These are like the non-negative least squares. This is like a single voxel fit using deep learning. And this is our SIMP-map. And we tested this with multiple SNRs. So basically, we repeat the experiment with 1 nex and 4 nexes. This took like 40 minutes, I think. And as you go faster and faster, all these methods become noisier and noisier, and we have like much more robust measurements. All right, so the summary of this last part is we can use synthesized brain images to improve training of deep learning algorithms. We currently test our methods in the context of myelin motor fraction mapping. We tested this with multiple sequences, 2D CPMG and 3D GRACE. Further evaluation is needed in clinical practice. We just started doing that for multiple sclerosis patients. I think that concludes my talk. I would like to acknowledge our funding sources, mostly NIH, and I would like to thank special thanks to all my colleagues. Simon Warfield, Olga Goldberg, and Philip Kruger are some of the PIs in our lab. If you notice, Tess Follis, Yao Sui, and Bahram Maramia were the previous fellows who actually did the work. We have some wonderful collaborations from radiologists, Dr. Sanjay Prabhu and Kamala Harnes, and some of our postdocs, Serge, Cemre, and Mustafa, and our wonderful collaborator from Siemens, Tobias Kober, who has been instrumental in developing motion correction technologies. So if you want to collaborate, feel free to email me. If you want to work with us, feel free to email me. We have lots of open positions. So I would like to thank for the invitation. If you have any questions, I'm happy to answer.
Thank you very much for this great talk. If you have any questions, please raise your hands, or for the virtual audience, please also use the Q&A box. Actually, there is already a question. Has there been an opportunity to use SLIMM approach in non-human primate imaging?
That's an excellent question. No, we actually do have a 70 clinical, 70 preclinical MRI, and we thought about that. So there were some problems with transferring the data in real time. So Siemens has like a very, for the human 3D scanner, Siemens has a very adapted, mostly for neurofeedback and like real-time fMRI studies. You can send DICOMs to a separate server very quickly. I think Bruker has some problems with that, so we worked on it, but we don't have anything that works at the moment.
Thank you very much. We had one question quite early on. Most probably it's already expired, but I just want to voice it from back in Bilgic. When actually Abbas asked the question, would it help to turn on GX and dissolve without access for the FID?
That's an excellent question. Yes, that actually does help, and we are trying to work on that. That actually gives you like an extra dimension, and yeah, that's actually almost exactly what we are doing at the moment. So excellent question.
Okay. Any questions from the audience? Oh yeah, I sorry.
So yeah, so basically we have a 3D radial, right? So we can actually generate like an image every, I don't know, like 16 seconds. So we use like, I think the first 45 seconds of this, the study to generate like multiple images of the 3D radial. So like some kind of an adaptive reconstruction. And we use that to train the pilot on. And I edited that slide like 2 hours ago, so that's why it doesn't have that much information. I'm happy to talk about that as well. So it's actually quite similar to how we will train an FID navigator or any kind of external thing. So yeah. Yes, yeah. It's a per subject thing. Yeah. So okay, that's actually a very good question, because for both the FID navigators and pilot tone, we couldn't do any like non-per subject thing. So it seems like there's something that these algorithms only were per subject. So it would have been wonderful if it didn't. That's like I think that's one of the downsides of this methodology. Yeah. So you need like some kind of a training or like for every subject. And that's why actually we developed this like synthesized motion, because then you don't have to ask the subject to move their head around. Because that was like the previous work from Toby's group. So you're asking the subject move around. You have an optical camera that tracks the motion. But then it's like counterintuitive. If you have an optical camera, use that. So it's kind of a chicken and egg problem, I think.
You made reference challenges and non-bridging.
Yes. So we are actually, basically the thing we are working on is, if you look at the slice to volume registration, we are trying to do like a non-rigid slice to volume registration. That's the thing that we work most. We have lots of work in doing radials in abdomen, so because they're more robust to that kind of motion. So our final strategy is like some kind of a binning approach that reduces the amount of non-rigidity and then do like a rigid correction in each bin and then combine the bins, if that makes sense. So it's like ongoing work. Yeah, but that's our, yeah, especially some of the, like, we have a project on Crohn's disease in bowels. That's like a disaster from a motion correction standpoint, because there's like peristalsis motion. It's like real challenging. Yeah. So if you're working on brain, work on brain. So I think that's motion correction on brain, much easier. Yes.
Sorry about that. Yeah. So we have one last question from the audience. For 3D radial acquisition, how do we calibrate the B0 map? Is it 3D?
Yes, it's a 3D map. That's why actually it's so it's almost the same as. Okay, so I see the, yeah. So, oh, I see the. So I'm here only showing, yeah. Okay, so I see where the question is coming from. I only show like the 2D field changes, but actually for the 3D radial we do like a 3D one. So this is this, I think, for the 2D GRE, and in 2D GRE we were doing like only the in-plane basically field changes, but for the radial we do like a 3D, and that actually is it makes it a little challenging. It's actually computational quite intensive, because you need to like simulate lots of parameters. So it's hard to do like a 3D one prospectively. So I think that's what the question is leading to.
Yeah. Okay. Thank you very much. Thank you very much for this great talk. It was amazing. And see you next week. Thank you.
Thank you.